Thank you for the introduction, and thank you, Beverly, for inviting me to come and speak, because it's a great forum to talk about this in. We're talking about increasing awareness, aren't we? And I don't know if any of you have seen a clot in a child or in an adolescent, or had a clot as an adolescent. Okay, so there's a few. Okay. But I just hope to give a bit of a brief overview and talk about some of the areas where I think there needs to be more work done. We're talking about gaps in care here, aren't we? So just a few disclosures in relation to mostly travel grants and also small grants for research projects. I suppose I should also disclose that I'm not actually a paediatrician. I'm not trained to look after children. But I'm an adult haematologist, and part of my work involves dealing with children with thrombotic and hemostatic disorders. And it's actually an area that I've gained a lot of experience in over the years, and it's my primary area of interest now is thrombosis in children and adolescents. So I hope you'll listen to what I'm going to say. So in terms of a summary, what I wanted to do was to talk about the epidemiology and the etiology of thrombosis in childhood. So how often does it happen, and who does it actually affect? What kind of children or adolescents are at high risk? Some of the consequences. So is it actually important? I hope to have convinced you that it is important. And then some of the challenges of dealing with thrombosis in children. So in terms of challenging diagnoses, anticoagulation and prevention of thrombosis in children, these are all areas where we've got really little knowledge. So thrombosis is not just for adults. I'm hoping to at least convince you of that. But it is fortunately far less common than it is in adults. So cases per 100,000 population in children, 1 to 5 cases per 100,000 population. And if you compare that to older adults, young adults, 30 per 100,000, and then older adults, obviously, the increased risk up to 300 to 500 per 100,000. So it is rare, but it does happen. And why is it so rare in children? I seem to have deleted one of the letters from the slide. This is Virchow, and he was a physician many years ago who talked about the 3 main risk factors that he felt contributed to thrombotic risk. So those were venous stasis, so basically immobility, which usually in adults is associated with comorbidity, so heart disease, lung disease, malignancy, etc. He also talked about vessel wall damage, so having damage to the vessel walls, which then meant, so like through surgery or lines, that meant that there was an abnormal area that clot could actually form and accumulate around. And then he talked about hypercoagulability, and there are lots of conditions that cause an increased risk of clotting, such as malignancy. It makes you more clotty. So when you think about children, they tend not to have comorbidities that give them venous stasis. They're generally pretty active. They're born with pristine vessels, clean vessel walls. So unless you start sticking lines into them or doing operations, their risk of clotting on a vessel is very low. And studies have shown that children have a much lower thrombotic potential. They're just generally less clotty than adults. Whoops. But despite a low incidence in childhood and adolescence, it is a diagnosis that's increasing in frequency. So we're making the diagnosis more and more. So this study was from children's hospitals in the United States and looked at rates of thrombosis in different age groups from 2001 up to 2007. And actually, this is for all age groups, showed a doubling in thrombosis incidence in all age groups of children. You can look here, so less than 28 days, 1 month to a year, sort of increasing in age. There was an increased incidence through all of those age groups. So we are seeing more and more thrombosis, or at least recognizing and diagnosing more and more thrombosis in children and adolescents. So why is that? Well, if you think about some of these things, these are all things that cause an increased risk of thrombosis in children. So prematurity, congenital heart disease and heart surgery, and cancer in children. And these were conditions that many years ago were often invariably fatal, or at least the survival was very, very low. But what we're doing now is we're successfully treating many of these conditions, but at the expense of an increasing risk of thrombosis. So all the things we do to these children in terms of putting lines in, doing surgery, giving them chemotherapy, all increase their risk of thrombosis. And I would hope that also, alongside that, we're actually developing more of an awareness of thrombosis in children. So it's something that we look for actively, it's something that we recognise when they have symptoms. So who gets it? Well, this was the very first registry study done in Canada in 1994 of children with thrombosis. And it looked at, within a single institution, a diagnosis of thrombosis in children, so going from age of less than 1 up to the age of 18. Now, what we actually saw from this very early study, and this has been reproduced in all of the other registries that have followed from various different places around the world, was there was a big peak in incidence in infancy. And that also the incidence seemed to be very low during childhood, early childhood, but then tended to rise into adolescence. And although there looks like there's a drop-off here in 16, 17, 18-year-olds, that's not actually the case. It's just that this was a paediatric hospital, and many of those 17 or 18-year-olds would be referred to an adult hospital. So what you actually really see is a rising incidence into adulthood. So why are the infants at risk? Well, those are the ones who are born prematurely, or they have congenital heart disease, or they need heart surgery, or they have multiple central lines in to keep them alive, essentially. And what about the adolescents? Well, you seem to see more of the sort of adult-type risk factors in adolescence. So children with cancer, often children with high-risk thrombophilic abnormalities, so antithrombin 3 deficiency, protein S deficiency, will present in the adolescent age group with their very first spontaneous thrombotic event, and often there's a family history that goes along with that. They may have had surgery, they may have had trauma, and then you can see some of the adult risk factors coming in, like obesity, smoking, contraception and pregnancy amongst those adolescents. And the main thing to take away from this slide, this is looking at associated conditions in children who have venous thrombosis. So with all the list of things that I've already talked about, but the main thing to note is that in less than 4% is there no identified cause. So unlike in adults, where about 50% of thrombosis is idiopathic, in children it's exceptionally rare to have a thrombosis out of the blue, apart from perhaps in those adolescents who've got an underlying thrombophilic abnormality. And when you look at the number of associated conditions, almost 80% of them have 2 or 3 associated risk factors for thrombosis. So on the whole, thrombosis in childhood tends to happen in a hospitalised population of children who are very unwell and have multiple risk factors for thrombosis at that time. Line-related thrombosis is key in paediatrics. The presence of a central line is the single most important cause of thrombosis in children, and it accounts for about 60% of thrombosis in children. And that's why, if you look at this boy who's got a central line in his upper venous system, where we often do place Hickman lines and porticasts for administration of treatment, chemotherapy, etc., that's why over a third of DVTs in children actually affect the upper limb rather than the lower limb, which again is very different to adults. So thrombosis outcomes in children, is it important? Are there consequences to having a thrombosis as a child or an adolescent? So if you look at all-cause mortality, kind of reflects the fact that these children are generally quite unwell. So up to a 15% mortality for all causes. Mortality due to the actual thrombotic event is around about 2%. So it is not insignificant. And then the risk of recurrent thrombosis seems to be around about 10%. So again, not an insignificant risk of having another clot when you've had one as a child. And then we'll talk a little bit more about post-thrombotic syndrome a little bit later in the talk. So the consequences. DVT in children, you can get post-thrombotic syndrome, and I will talk about that. But another major issue in children is loss of venous access. So if they're reliant on their venous access for administration of treatment, sometimes for parenteral nutrition in children who've got no gut to absorb their nutrients, you start clotting off all of those vessels that you've put the lines in, and soon you run out of somewhere to put a line in, and that can be life-threatening for a child. PE carries a mortality of about 9% in children, and there are cases of children developing chronic complications like pulmonary hypertension. And if you have a clot within a vessel within the kidney or the liver, again, you can develop organ failure as a consequence of that. So it is important. Post-thrombotic syndrome. So I'm not going to go into the features of PTS. You know those: chronic limb swelling, discomfort, fatigability of the limb, change in appearance, at the worst, venous ulceration. They're exactly the same in children, and children do get PTS. And actually, it's said to be in around about 10 to 25% of children who have this. And think about the consequences of that for a child. If they have PTS, the natural history is that it doesn't go away. It may stay stable at best, but it may well get worse. And that child may have those symptoms then for the rest of their lives, which can be 7 or 8 decades. So it's a significant thing. And we're always trying to pick up on these risk factors so we can try and think about how we might prevent PTS in children. So certainly children who present at a younger age with thrombosis, if they've got very extensive proximal thrombosis at presentation, if there's any delay in anticoagulant therapy, or if they've got residual thrombus left at the end of anticoagulant therapy, they are more at risk of developing PTS. This is a child who's had an upper venous system DVT, very subtle really in this case. You can just see those distended vessels on the chest wall and the upper arm. Perhaps more extreme, this is a young girl who had short gut syndrome, so she was reliant on TPN for her nutrition. She'd had multiple line-related events. She'd had multiple lines put in, they'd all clotted off. So she basically has, varicosities on the upper chest wall. This is a 5-year-old girl, and she will have that for the rest of her life. That appearance will never get better. I've had to tell her parents that, you know, at best it will stay much the same. So a huge impact for some of these children. And then a young lad with venous ulcers, which do occur, fortunately rarely in children, but they can occur in children and adolescents. Just a little note about compression stockings and a little anecdote. So I wrote up this case several years ago now. This was a 6-year-old boy who'd actually, as a neonate, had been a premature neonate and had had multiple interventions and multiple lines when he was born prematurely. And he'd had multiple line-related clots, but the most significant seemed to have been in his left common femoral vein. So he'd had a proximal line and he'd had a proximal DVT, which was appropriately treated. Was coming to regular follow-up in the clinic. And actually, you know, you can't really see much here. He's perhaps got a slightly bulky left leg. You can perhaps see it a bit better, that puffiness at the ankle, but it's pretty subtle. But his parents reported that at school he was getting into trouble. He wouldn't sit still when they sat on the floor for circle time, for stories, and he was up and he was about, and they thought he was just a naughty boy. And then when they went outside and they did PE, he just wouldn't join in. He would run for a bit, but then he would just stop and he didn't want to join in. So I discussed with the mum and I said, well, why don't we try a compression stocking? Because it might be that he's getting aching or fatigability of the limb, and that's why he's not doing what he should be doing as a young boy. So we prescribed a compression stocking. His mum said there is absolutely no way on this earth that he's going to wear this. He won't even put it on. She put it on day 1, and then he refused to take it off, and he wore it religiously, and he became a completely different little boy. So he would sit infinitely cross-legged for circle time, and very attentive young boy. He started playing football with his friends. He just became a completely different child. So we can measure up compression stockings for children as young. Well, the youngest I've applied one to was 14 months old. They have to be custom fitted, obviously, so they have to go and be measured up in the surgical appliances centre, but they can fit them, and they can be extremely useful for some of these children. And of course, in the younger ones, they're not actually able to tell you their symptoms. So sometimes you have to say, well, actually, this might be PTS. We'll try a stocking. We'll see if it makes a difference. It might not, but we can try. Just a quick note about cerebral sinus thrombosis. So this is, I think in children, you tend to see that you get more of those unusual site thromboses than you do in adults as a proportion. So cerebral sinus thrombosis, often seen in children who have a head and neck infection. So if they have a really severe inner ear or middle ear infection or a mastoiditis, because of the inflammation near the sinuses of the brain, they can then develop cerebral sinus thrombosis. And then another setting is in the treatment of acute leukemia, where asparaginase is a chemotherapy drug that's used and it increases the risk of thrombosis. And for some reason, that seems to present with cerebral sinus thrombosis. So clots in the brain, mortality of about 10 to 30%, is very significant. But the morbidity is also very significant. In about 50% will have ongoing headaches, seizures, obvious limb weakness or numbness, and then things that we just really don't know much about, so the subtle cognitive deficits and behavioural problems that might be a consequence of having had an intracranial thrombosis. We've heard a lot about this, and it's a hard act to follow. Dr. Noble, it's a hard act to follow. This psychological effects of thrombosis, an area that's had no research really in children. This article was actually quite interesting. I found this on the Thrombosis UK website. I wasn't aware of that until I had a look. So this looked at young people aged 13 to 33 years with their first episode of thrombosis, and followed them up for 5 years and looked at prescribing of psychotropic drugs. So these were drugs that we use for either anxiety, depression, or sedatives to help them to sleep. And that was taken as a proxy for individuals that may have been experiencing psychological issues in relation to their thrombosis. And they found that there was a twice baseline risk of these individuals being prescribed these drugs out in the community, suggesting that perhaps they were psychologically affected by their thrombotic event. And that risk persisted after adjusting for significant illness like malignancy and pregnancy, etc. So that did include some children, that study. And what might those effects be? So why would children have a psychological effect? And, do children worry about things? We don't really know. I think children do worry about things more than we think. So worrying about thrombosis, recurrent thrombosis or death. So I've seen a 16-year-old recently with a PE which was related to oral contraceptive pill. She was went to A&E for the third time yesterday with non-specific symptoms, breathlessness on exertion, chest pain, which was put down to anxiety. She told me in the clinic that she said that every time I get breathless when I climb the stairs, I know it's because of my PE and I know that I'm still recovering. It was very recent. So every time I get breathless, I think I'm going to drop dead with a PE. And she, obviously very distressing for her. Fear of anticoagulant-related bleeding. So clearly these children and adolescents are anticoagulated for their clot. The young girls often have heavy periods because of that. That can be distressing for them. They can end up staying at home rather than going to school because their periods are so heavy. Nosebleeds, bruising. They may worry about the monitoring, having to go to the clinic to get their INR monitored on warfarin. And there may be influences on their lifestyle in terms of their diet and alcohol in the older adolescents. Children can have hospital-related anxiety. There can be needle phobia, either through doing the finger prick INR test for warfarin monitoring or giving daily low molecular weight heparin for thrombosis. And then the restriction in their physical activities because they're anticoagulated and at risk of bleeding with trauma. We'll talk in a bit about activities that we prefer them not to do, or through being restricted because of their symptoms of post-thrombotic syndrome or pulmonary hypertension. And children must in some way feel different to their peers in that respect. And I think one key thing is that there is a lack of support groups. It's a rare diagnosis. There's not much information available for either patients or parents in this setting. So just a little bit about challenges in the management of childhood thrombosis. So like I say, it's very low in incidence, so it makes it really hard to gather enough patients together to do properly controlled or properly powered randomized controlled trials. So those just simply haven't happened. The current evidence is weak. So we use this American guideline. It's globally accepted as the guidance for managing thrombosis in children. But when you look at the actual recommendations that are made, more than 3/4 of them are grade 2C or above, which basically means that those recommendations are based on consensus and a lack of evidence, really. A lot of the guidance that we use in children and adolescents is based on adult data. The studies just haven't been done in children, so we just have to assume that we're choosing the right anticoagulant, it's the right intensity in terms of INR ranges, and it's the correct duration, but we just don't know for children. And because of that, there's a considerable variation in practice across the UK and across the world, which makes it difficult to glean any information. I just wanted to highlight this, delay in diagnosis. So we recently looked at 76 cases of thrombosis in adolescents we found that delay in diagnosis of greater than 24 hours from presenting with the symptoms was around about a quarter. But interestingly, the average delay in diagnosis in those where there was a delayed diagnosis was really quite significant. So for those with DVT and classical symptoms of DVT, the average delay in diagnosis was 3.5 days. For PE was 10 days. And it's unbelievable, really. Reading some of these case records that I looked at, I'm like, well, why didn't they know that this was a PE? The child was hypoxic, they had pleuritic chest pain, they had all of the risk factors. I think one of the problems is that this is generally a very sick bunch of children, and they often have a lot of other conditions that might account for those symptoms. So you really have to have a very high level of suspicion before you go looking for PE and DVT. And then another issue was that even when it was thought about, pending investigation, very few of those individuals were given low molecular weight heparin, injectable heparin, while they waited for their scans. Anticoagulant therapy, we basically have two choices really in children. We either use injectable low molecular weight heparins on a daily or twice daily basis, or we use oral anticoagulants at the moment, warfarin. There are limitations of both. Obviously, injecting a small child twice a day is not great. Parents usually do it. If the parents aren't happy to do it, a community nurse has to come in, and of course the parents are then restricted because they're waiting for the community nurse to come twice a day. Low molecular weight heparin in children has to be monitored by monthly blood tests because we don't really know enough about the pharmacokinetics and what doses we should be given. The child can have obviously a needle phobia, and sometimes the parent has a needle phobia too. And we don't really know about the long-term effects because obviously in adults you usually use low molecular weight heparins for a short period of time, excluding those with malignancy-related thrombosis. But in children you may be treating for a number of months or years with low molecular weight heparin. Problems with warfarin, tablets only. So if you're having to give 0.5 milligram doses or fractions of doses, you're having to crush tablets, dilute it, and then give the appropriate volume, which doesn't lead to the most stable of dosing. And then all of the things that interact with warfarin, so illness, sort of febrile illness, diarrhea and vomiting, needing to have antibiotics for chest infections, variations in diet, they're all amplified in children. So managing warfarin in a child can be very, very tricky. So for that reason, we tend to use low molecular weight heparin daily or twice daily injections if the duration of therapy is to be less than 3 months or if the child is very young. Whereas the older children and the adolescents and those who are likely to be on long-term therapy will be on an oral agent. Things to make it easier. Like I say, obviously injecting into a small child on a daily or a twice daily basis can cause a lot of bruising. It can be quite traumatic for that child. Some people will use a subcutaneous port or an insufflon device to actually put it just under the skin. It's taped on, and then the injectable heparin is pushed through that port, and those can be kept in for about 7 days. In terms of warfarin, I mean, look at this. When we look at studies looking at time spent within target range in children on warfarin, they're within target range about 50 to 60% of the time at best, to be honest. So we need to monitor them very closely. Most children or adolescents will be issued with a home monitoring device. And we fight long and hard to get hold of those and to get the funding for those because I think it's really important. Not only does a child not want to miss school or college to go and get their INR check, but also the parents who have to take them will be missing their time in employment as well. Restriction of physical activities. Sorry? 1 minute. All right, okay. I'll just quickly go through this. So obviously physical activity is important to reduce risk of thrombosis recurrence. But there are a couple of contact sports that we say absolutely no way when you're on anticoagulant therapy. So rugby, boxing, and some of the martial arts like kickboxing, you obviously want to avoid the risk of significant injury and head injury and bleeding. And then it's important to wear helmets and protective equipment as needed and to make sure that the child's PE teacher knows that they're on anticoagulant therapy. I'll not go through prevention given the time. Just a quick look to the future. Direct oral anticoagulants, so we're hearing a lot more about those now, and they're coming into routine practice in adults. Now, the studies really are just up and running now in children. We're running a couple of phase 2 and phase 3 studies of rivaroxaban in the UK, looking at use of those treatments in children with thrombosis. The benefits, potentially, of having an oral agent that you could give to any child at a predictable dose without needing the monitoring of warfarin are huge. So I think it's really important that these studies go ahead and we get, finally, potentially a licensed medication for thrombosis in children. Last slide. Just in thinking about the remit of this meeting, identifying and plugging the gaps in care, I think there are a few key things in childhood thrombosis. We need to reduce delays in diagnosis, so we need to increase awareness. That's why I'm here. We need to try and look at multi-centre, multinational, randomised controlled trials to look at the best management of childhood thrombosis. I think we should be developing more the use of the direct oral anticoagulants because they have a real role to play, I think, in paediatrics in terms of their advantages. We need to look at preventative strategies in children, and we also need to look really closely at the effect of thrombosis on quality of life, not just of the child, but of their parents and their siblings as well. And I think we need to be providing more information for patients and parents out there and better access to support groups. Sorry to have gone over time.
Particularly as the food's coming in, the smells are wafting off, it's important to time. I've got one question, and then target ranges for children. So how is that determined?
Well, for warfarin, it's been extrapolated from the adult data. So for a first thrombosis, we would aim for an INR of 2 to 3. For recurrent events, we might increase that target range. Same for low molecular weight heparin, aiming for 0.5 to 1, 3 hours after the injection. But really, the work hasn't been done. It's all been extrapolated from adult data.
Thank you very much, Tina.
Thanks.
You highlighted the psychological effects. I've got a teenage clinic that come weekly, and we have a clinical psychologist attached.
Fantastic. Lucky you.
It's really difficult to
Yeah.
be a teenager
Yeah.
and then to get a chronic illness.
Yeah, absolutely. And as we were hearing earlier, I mean, the child with cancer, it's all kind of dealt with. It's part of the package of care, isn't it, to have the psychologist involved, to have the play therapist and the education, etc. in hospital. It's not a part of routine thrombosis care.
Any last questions? Okay.
So I was 13 during my first DVT, and later on, it was discovered that it's due to major health. Do you often see children?
I've seen a few,
I've never
yeah.
actually been told the age at which
Yeah.
anatomical
Can
thing
be
comes into play.
often in adolescence. Often in adolescence, and there are there's May Turner that we've heard about already today. There's also thoracic outlet syndrome that can cause upper limb DVT. So one thing, I didn't have time to talk about it, but one thing that we actively go looking for, so in an individual at 13 with a massive lower limb DVT, we would actually ask radiology to have a real good look to see if there's any evidence of a congenital anomaly.
Discovered until I was 19. So
Yeah.
then spent it.
Yeah, and some children have IVC anomalies, so they, yeah, absolutely.
Okay.
Thank you.
Very much.